Hello, everybody. I'm Marinos Dalakis, and it's a pleasure to chair this session on inflammatory myopathies. I call them autoimmune inflammatory myopathies because I don't think they're idiopathic. So we have several great speakers to highlight the new events on inflammatory myopathies and how the field is going. And it is again a pleasure to chair this session and I'd like to thank the speakers for accepting and participating on this field. It's a field that is greatly expanding, and I'm personally very happy to see this. So we'll start with the first speaker. The first speaker is Dr. Andrew Mammon. Andrew was at Johns Hopkins and is still at Hopkins, but he has built a very a great muscle unit at the NIH, at the National Institute of Arthritis and Musculoskeletal and Skin Diseases. And he is going to talk to us about the advances in the immunopathogenesis of inflammatory myopathies, especially the validity and the pathogenic significance of the various autoantibodies, as well as the innate immunopathology observations. Andrew, welcome.
Hello, my name is Andy Mammon. I'm a senior investigator at the National Institutes of Health in the muscle disease unit here within the National Institute of Arthritis and Musculoskeletal and Skin Diseases. And the title of my talk today is going to be Advances in the Immunopathogenesis of Inflammatory Myopathies. As a disclosure, I am a patent holder for an anti-HMGCR autoantibody test, but I do not receive compensation for this. In terms of overview of today's presentation, I'm going to be first talking about the different types of inflammatory myopathy. What are the main types? Then I'm going to talk about whether myositis-specific autoantibodies might be pathogenic. And then I'd like to address whether there could be a causal link between cancer, which is seen at an increased rate in patients with dermatomyositis, and dermatomyositis-specific autoantibodies. So first, what are the main types of myositis? So the first main type of myositis is inclusion body myositis. Muscle biopsies are characterized by endomysial inflammation. These would be CD8 positive T cells invading myofibers. And in many cases, the muscle fibers have rimmed vacuoles that allow you to make a diagnosis of inclusion body myositis. These patients also have a characteristic pattern of weakness with prominent quadriceps weakness and distal finger flexor weakness. Unfortunately, these patients tend to be quite refractory to treatment, and I believe another speaker today is going to be going into more detail about inclusion body myositis. The second major type of myositis is dermatomyositis. Of course, these patients have not only muscle involvement, but also skin involvement. If you look at muscle biopsies, the classic feature would be muscle fascicles with perifascicular atrophy. So the myofibers around the edges of the fascicles are small compared to the normal sized myofibers at the interior of each fascicle. Of course, they have these classic rashes, the heliotrope rash, which is the erythematous lesions over the upper eyelids here, and Gottfried's papules over the extensor surfaces of the MCP, PIP, and DIP joints. There are myositis-specific autoantibodies associated with dermatomyositis, and these include antibodies that recognize MI2, TIF1 gamma, NXP2, and MDA5. And some patients, probably about a third, seem to be antibody negative. The third major type of myositis is the anti-synthetase syndrome. These patients are defined by the presence of autoantibodies that recognize one of the tRNA synthetases. The most common autoantibodies are those against histidyl tRNA synthetase, otherwise known as Jo1. And along with PL7, PL12, and EJ, these are the four most common anti-synthetase autoantibodies. I show you an identical muscle biopsy as I showed for dermatomyositis to remind me to tell you that you really can't distinguish dermatomyositis muscle biopsies from anti-synthetase syndrome muscle biopsies, at a histological level, they appear pretty much identical. But patients with the anti-synthetase syndrome don't just have muscle involvement and then sometimes skin involvement, but they also often will have one or more of the following: interstitial lung disease, arthritis, mechanics hands, and/or Raynaud's phenomenon. The fourth major type of myositis are the necrotizing myopathies, or immune-mediated necrotizing myopathy, and these patients have prominent myofiber necrosis on their muscle biopsies without significant inflammatory infiltrates. Classic autoantibodies associated with necrotizing myositis are those against the signal recognition particle, or SRP, or HMGCR. That would be HMG-CoA reductase, which is the pharmacologic target of statins. The fifth major type of myositis is overlap myositis. That's when you have an inflammatory myopathy in the context of a distinct rheumatologic disease like lupus or scleroderma. And these patients may have myositis-associated autoantibodies, but not myositis-specific autoantibodies. Then I think the new kid on the block here is immune checkpoint inhibitor-associated myositis, which I'm not going to talk too much about today. So you might ask, well, what happened to polymyositis? I thought polymyositis was one of the main types of polymyositis. I think as neurologists, we've known for probably 20 years or so that polymyositis is rare, if ever the actual diagnosis for patients. And now, 20 years later, I think rheumatologists are starting to realize that most patients previously diagnosed as polymyositis probably have another type of myositis, at least by today's modern classification criteria. And that would include patients with inclusion body myositis, and many patients that are diagnosed with polymyositis we have found actually have inclusion body myositis. Also, patients that we would now characterize as having immune-mediated necrotizing myopathy at one point would have been called polymyositis. Patients with the anti-synthetase syndrome but who do not have cutaneous manifestations would have been called polymyositis. Overlap myositis patients would often have been called polymyositis. And finally, a significant number of patients previously diagnosed with polymyositis we now recognize have inherited muscle diseases that often have inflammation in them, like facioscapular humeral dystrophy or dysferlinopathy. Those would be two examples of genetic muscle diseases that in the past would have, unfortunately, before genetic testing was as easily available, been misdiagnosed as polymyositis. So the next question is, are myositis-specific autoantibodies pathogenic? And I just want to provide a few cases where there is some experimental evidence that that these autoantibodies might indeed be pathogenic. So first, back in 2007, Dana Asherman and his colleagues published this paper showing that if they immunized mice with Jo1 protein, that the mice would develop not only lung, but also muscle inflammation. I show you here some examples of the mouse muscle with inflammatory cells. Here is an example of lymphocytes surrounding and potentially invading a muscle fiber. So this was some evidence for perhaps an immune response against Jo1 leading to muscle inflammation, at least in the mouse. More recently, colleagues in Japan found that if they immunized mice with TIF1 gamma, which is one of the dermatomyositis-specific autoantibodies, that these mice also develop myositis, and they showed some endomysial inflammation, some myofiber necrosis, and also what they described as perifascicular atrophy, which is kind of the hallmark of dermatomyositis in these mice that had been immunized with the TIF1 gamma protein. So these are observations in mice. I want to go a little bit deeper and talk about what we thought was the case for autoantibodies being pathogenic in necrotizing myositis with anti-SRP or anti-HMGCR autoantibodies. So first of all, our group and others found that the titer of these autoantibodies, especially HMGCR autoantibodies, was highly correlated with disease activity, in this case as evidenced by a relationship between the HMGCR titer and the CK levels. Similarly, we could find that the higher the HMGCR titers were, the weaker patients were. And the same could be shown also for anti-SRP autoantibodies. Histological analysis of muscle biopsy tissue from anti-SRP and anti-HMGCR cases revealed that there is membrane attack complex present on the surface of what appeared to be non-necrotic muscle fibers in both types of myositis, both anti-SRP and anti-HMGCR. Work done by colleagues in France showed that in human muscle biopsy specimens, that there's a strong correlation between the degree of complement deposition within the muscle biopsies and the amount of myofiber necrosis. So the more complement deposition there was, the more myofiber necrosis there appeared to be. And then moving to an animal model, these investigators showed that if you take immunoglobulin from patients with SRP or HMGCR myopathy and inject it into mice, that the mice have decreased grip strength compared to mice that were injected with healthy control immunoglobulin. They also showed that these mice who were injected either with anti-SRP or anti-HMGCR autoantibodies could develop some myofiber necrosis as well, again suggesting that the antibodies were pathogenic. And then they addressed whether complement was necessary for the antibodies to cause myofiber necrosis and decrease muscle strength. And what they did in this case was to treat complement deficient mice with either anti-SRP or anti-HMGCR IgG. And what they found is that the complement deficient mice did not have a decrease in muscle strength after being treated with the potentially pathogenic antibody, suggesting that the effect was mediated by complement. So based on the observations in human tissue, as well as observations from this mouse model of immune-mediated necrotizing myopathy, which was really a passive transfer model, we and others took part in a clinical trial of a complement inhibitor called zilucoplan, which is a C5 inhibitor that is administered subcutaneously. And this was a phase 2 double-blind multi-center trial sponsored by UCB, in which half of the patients received zilucoplan and half the patients received placebo. And in order to be included in the study, you had to have either anti-SRP or anti-HMGCR myopathy. And these were patients who had been refractory to other treatments. So the primary endpoint of this study was to look at CK levels 8 weeks after starting either zilucoplan or a placebo. And we chose this as the endpoint because we know that myofiber necrosis and elevated CK levels are highly correlated with disease activity in these patients. But we also looked at other endpoints, including manual muscle strength, the walk tests and get up and go tests and so forth. But the unfortunate news for patients is that zilucoplan really had no demonstrated ability to improve muscle strength, CK levels, or any other relevant disease activity markers in our patients with immune-mediated necrotizing myopathy. And this was really a very clear negative trial. So based on this, we can conclude not only is complement inhibition not an effective treatment for anti-SRP or anti-HMGCR myopathy, but also that the destruction of myofibers by antibody-mediated complement deposition is not the primary mechanism of muscle injury in patients with necrotizing myositis. And also, I think another takeaway from this is that mouse models of myositis may actually have only a limited relevance to human disease. So it raises some questions about those models involving JO1 or TIF1 gamma immunization as well. So the last part here, I'd like to emphasize the potential link between cancer and dermatomyositis, and specifically dermatomyositis-specific autoantibodies. So it's been known for quite a while. This is about what I'm showing you here is about a 10-year-old meta-analysis. It's been known for quite a while that TIF1 gamma autoantibodies, also known as anti-P155 autoantibodies, are highly associated with malignancy. And in this meta-analysis, including 53 cases of cancer-associated myositis among 312 adult DM cases, patients who had anti-TIF1 gamma autoantibodies had a significantly increased rate of malignancy. And in fact, the positive predictive value of a anti-TIF1 gamma autoantibody was about 58%. If you didn't have the anti-TIF1 gamma autoantibody, there was about a 95% chance that you did not have an underlying malignancy. So these autoantibodies against TIF1 gamma were highly associated with malignancy. Now, we went looking for novel autoantibodies in patients with dermatomyositis, and we found a novel autoantibody recognizing a protein called transcription factor SP4. And we did this in a collaboration with Bed-Larman, where we used phage immunoprecipitation sequencing to identify novel autoantibodies. And what we found were that these anti-SP4 autoantibodies were present in about 11% of dermatomyositis patients. And virtually all of those patients with anti-SP4 antibodies were also positive for TIF1 gamma. So at first it seemed maybe this was not so exciting until we started looking carefully at the clinical features of these patients. And what we found is that the anti-SP4 autoantibodies identify those TIF1 gamma positive patients who do not develop cancer. So again, if you have TIF1 gamma, you're overall at increased risk of having malignancy. But if you also have anti-SP4 autoantibodies, you do not have an increased risk of developing cancer. So this suggests that patients who are TIF1 gamma positive, but also anti-SP4 positive, probably do not need super aggressive cancer screening like we tend to do in other dermatomyositis patients. My colleagues at Johns Hopkins, including Livia Casciola-Rosen and David Fiorentino at UC at Stanford, have found another protein against CCAR1, which is also an autoantigen in dermatomyositis patients, and it also identifies a group of TIF1 gamma positive patients who are not at increased risk for malignancy. So it's not just SP4, but also autoantibodies against CCAR1, which seem to be protective against malignancy. So what's the relationship now between cancer, autoantibodies, and dermatomyositis? So one hypothesis is that perhaps tumors precipitate an anti-tumor response, and sometimes it leads to autoimmunity, such as dermatomyositis. We and others have proposed that perhaps TIF1 gamma immune responses elicit dermatomyositis, but do not eradicate the tumor, and hence those patients have an increased risk of malignancy. On the other hand, if you develop autoantibodies and an immune response not just against anti-TIF1, but also against anti-SP4 and or CCAR1, that you may get dermatomyositis, but the immune response is strong enough to eradicate the tumor. And that's why these patients would appear to be protected from malignancy. However, I would draw your attention to the fact that children who develop dermatomyositis can have anti-TIF1 gamma autoantibodies, but they are not at increased risk for cancer. And furthermore, about 20% of kids with anti-TIF1 gamma positive dermatomyositis also have anti-SP4 autoantibodies, even the ones without those antibodies don't have cancer. So it's unclear exactly how to interpret this. It could be that tumors don't promote an immune response against TIF1 gamma or SP4, or, and I favor this hypothesis, it could be that tumors do arise in children and they can precipitate dermatomyositis, but they're eliminated more easily and perhaps by an anti-TIF1 immune response alone. So that is mostly what I wanted to tell you about what's new in the immunopathogenesis of myositis, and I thank you very much for your attention.
Excellent. Thank you, Andrew, for this nice talk. We have one question from the audience, but I'm going to start with one or two questions that I have. First, I'm glad you mentioned that these mice animal models are not really very convincing. We have to be careful to interpret them because I have been also critical for many years about that. So I'm glad you highlighted this. The second is about the complement. I have been also critical that the complement is not really specific for necrotizing myositis for many years because we see complement in muscle fiber necrosis due to any cause. In muscular dystrophy patients, we know for many years that they have complement on the muscle fibers. Complement mediates the necrosis and plays a role anyway. So I was not surprised that the study was negative. So I want to see your thoughts if you think, as some people have said, that these autoantibodies are complement fixing, although they are not really complement fixing, they're just the complement is there for other reasons. So what are your thoughts?
Yeah, so I originally did think it was likely that that the immune-mediated necrotizing myopathies were that the antibodies themselves were pathogenic and that they were likely pathogenic by somehow fixing complement on muscle fiber membranes, but I was proven wrong by the experiment that was done in human. You turn out to be absolutely right in your long-held beliefs that it is probably not a primary mechanism of muscle damage in those patients, as far as we can tell. So I would have argued strenuously with you about it a couple of years ago, but now I have to admit that that I was wrong.
No, that's fantastic. I appreciate that. That's it happens to all of us. So it's yes. So then I'm going to read the question of the audience to make sure we give credit to the audience. There is a question. Thank you for the presentation. Is there any specific recommendation regarding the cutoff time for myositis-specific autoantibodies after a patient has received corticosteroid therapy?
So that's a very good question. So in most cases, at least relatively early on, even after treatment, the antibodies persist. In some types of myositis, we see the antibodies continuing to persist even when there's very minimal disease activity. For example, in our anti-HMGCR patients, we can have very little disease activity and the antibodies will still be there. With types of myositis, and Iago has shown this, for example, in M2 positive dermatomyositis, if the disease has been well treated for a long time, the antibodies can actually go away. So some of the antibody DM we see might either be because the antibodies haven't been generated yet, or potentially they've gone away, or dermatomyositis-specific autoantibodies we haven't yet discovered. But there's no absolute off. We always check for them, even if it's been years and years that the patients have had disease, and we will often find them. And definitely, if their disease is still active, we would expect to find them if they're there.
Right. We still have time for some questions. So maybe I can also ask another one. Andrew, you mentioned that the anti-synthetase histology is almost identical with dermatohistology, and I was wondering if you have looked at this sort of more extensively, because in dermato there is perifascicular atrophy, complement deposition on the blood vessels, so there is reduction of the capillaries. And in contrast, in the anti-synthetase, there is more necrotic fibers at the periphery rather than atrophic. So do you think these are helpful in distinguishing histologically the two?
So I would say that you're absolutely right. There are trends that tend to favor one more than another. So there's more, for example, perifascicular necrosis in the anti-synthetase syndrome. About 80% or so of the anti-synthetase patients will have perifascicular necrosis, where it's only about 60% of dermatomyositis. And but I don't think that's actually that helpful. I'm not sure about, we haven't looked ourselves at capillary density, so I can't really answer that question about whether that separates them. But what I can tell you, again, this is really based on work that Iago's primarily done, looking at the transcriptomic features of muscle biopsies. The anti-synthetase muscle biopsies are transcriptomically easily distinguished from those that come from dermatomyositis patients. They have totally different transcriptomic signatures. So I do believe that they're different, and maybe an excellent neuromuscular pathologist can tell the difference. But I think in clinical practice, most people can't tell the difference between them just looking at the histological features.
So we have two more questions. So then it's follow-up questions from the audience is how accurate are the immunoblots myositis specific antibody panels that are commercially available?
Yeah, so that's an excellent question and a moving target. So there are I can't give a very simple answer to that. What I can tell you is that we recently convened a study group, the European Neuromuscular Center study group, to come up with some guidelines about what testing was best for each individual antibody, including the sort of different platforms. So there's a paper in Neuromuscular Disorders on autoantibody testing that has a table in there, goes through each antibody and what testing and where it can be obtained that's most accurate. What I say is, from a practical point of view, we use OMRF, which is a United States-based testing center, and we find them to be sort of our clinical gold standard. But the other thing I would say is there are other testing platforms, and they keep getting better. So it really depends on what's available to you locally.
Yeah, thank you, Andrew. There is one comment. We have only a few seconds. There is only one comment from Tassin Mozaffar, who said in the original JNP paper in 2000, Alan Pestron and himself showed that the capillary density is normal in Zone 1 myositis, which is also my own assessment. So I think it is the end, because we don't have more time, but I appreciate your talk, Andrew. It's very helpful and very enlightening. So I'm sure there will be more to come. So thank you very much. So we go to the next speaker.
Good afternoon. My name is Rodrigo Frisati. I'm a PhD student in the University of São Paulo, Brazil, and also ICG-MD Fellow. I would like to say thanks to the organizers to give me the opportunity to present this case. I have no conflicts of interest regarding this presentation, and our aim is to describe a self-limited case of anti-AGM-GCR necrotizing myopathy in a child after dengue infection. We would like to raise at least two important considerations. Would dengue be a potential trigger for antibody production? And second, would it have a correlation with the unusual clinical presentation that we are about to see? Regarding background, we know that dengue is an arbovirus with 4 defined subtypes. It has a broad range of clinical manifestations, ranging from asymptomatic cases to life-threatening conditions. It has been previously associated with an increase on the risk of autoimmune disorders, and this is an endemic disease. This is endemic in Brazil. We know regarding autoimmune myopathies that we have this classical clinical classification in which we have polymyositis, dermatomyositis, and immune-mediated necrotizing myopathies. But in the last years, we are moving into the myositis-specific autoantibodies classification, in which we have different antibodies with different phenotype correlations. One of these group of correlations is the group of necrotizing myopathy, in which we have the AGM-GCR antibodies. Regarding the autoimmune myopathy associated with these antibodies, we have a few important considerations to make. First, this is not only related to statins, even though that this is the classical trigger described initially. Second, it's a highly specific autoantibody. Third, we have this classical adult onset subacute proximal predominant weakness with high elevation of CK fibers in the muscle biopsy showing necrosis and dependence on immunomodulation. But we do have different phenotypes. One of them is the chronic, resembling a limb girdle muscle dystrophy phenotype, especially in children. Children are non-statin exposure much more frequently than adults, and they usually have a worse prognosis. And the fourth, we have some expected findings on the complementary evaluation. We expect to see posterior and mid-thigh abnormalities on MRI. We expect to see necrotic fibers with increased MAGC class 1 on the muscle biopsy and a myopathy with membrane instability on EMG. Our patient is a female patient, daughter of non-consanguineous health parents, previously diagnosed with a congenital hypothyroidism, but without any other comorbidity. When she had 10 years old, she had a mild dengue infection. She didn't have a lot of problems with that, but 2 weeks later, she developed a proximal lower limb predominant weakness with myalgia and elevation of CK levels. The weakness progressed, and after 7 months, she was wheelchair dependent. The patient lives in a state really far from our hospital, more than 1,000 kilometers. So we didn't see her until 1 year and a half from the beginning of symptoms. But when we first saw her, she had this global weakness with proximal lower limb predominance, diminished deep tendon reflexes throughout, and normal sensory examination. We went for EMG that reviewed normal motor nerve conduction study, a sensory nerve conduction normal as well. But on the needle examination, we can see this myopathic motor unit axial potential with membrane instability. And on the lab exams, the most important features are the elevation of the CK that is persistent throughout the years. And we can see here that the hypothyroidism was not well controlled throughout the years. This is another important feature for our discussion. And within these tests, we decided to go for muscle biopsy. But unfortunately, again, because of the distance from where the patient lives to our hospital, we couldn't do this muscle biopsy until 2018. And the muscle biopsy is shown here. We have some findings that, even though are unspecific, that they can fit on a diagnosis of a necrotic myopathy. We have some necrotic fibers, we have some atrophic fibers with non-muscle fibers groupment, revealing that this is a myopathic process, not a neurogenic process. We have this lipid accumulation and the MAGC class 1 staining. Even though it's a slight staining, we do have this staining here, as we can see on the photos. So with these in hand, we decided to go for a muscle dystrophy panel, because at first it was a really progressive course and the patient was improving, even though she didn't receive any kind of immunomodulation. So we first went for a gene panel that was negative. Even though this is not a holoexome sequencing, this is a gene panel, it includes the most important autosomal recessive causes of limb girdle muscle dystrophies, including CAPN3 and DISC genes. So with this negative result, then we decided to go for the HMG-CR antibodies analysis. And for our surprise, 7 years after the beginning of the symptoms, we can see a positive result with high levels. So we went for MRI, and we can see here, unfortunately, with low quality because the patient did it on her CD. We can see some proximal predominant on the posterior mid-thigh abnormalities, a lot of liposubstitution, only a few asymmetry, and we can see here that this is a predominance on the posterior compartment. And even though we have some asymmetric changes, we don't have a lot of edema, a lot of active process, at least suggested on this MRI. So to summarize, we have a patient with persistently elevated CK levels, high titer of anti-HMG-CR antibodies, an MRI and a biopsy that, even though are unspecific, can fit, suggests the possibility of a necrotizing myopathy. But we do have some confounders. Indeed, we have this hypothyroidism with irregular control. We have the limitation on the genetic analysis that we conducted, and we have this lipid accumulation on biopsy that this is an unexpected findings for necrotizing myopathy. But the most important feature is how the patient is now. How the patient is now 7 years, 8 years after the beginning of symptoms. And the patient is quite well. She can do everything of daily living without any kind of functional impairment. Even though she had this aggressive beginning of symptoms, she spontaneously improved. And that's the major point to be discussed. We decided until now not to treat her because even though she had these markers suggesting an ongoing process, the patient is quite well. The patient doesn't have almost any kind of weakness on the physical examination. So we would love to hear from the audience what you think about the case and to discuss this on the question and answer section. And we would raise these points for discussion. First, would dengue be a potential trigger for the antibody production? We feel that yes, because we already have this correlation in literature, and we have this temporal correlation in our case. The next step would be to investigate if there is a high prevalence of necrotizing myopathies in countries that are endemic for dengue. Second, would it have something to do with this unusual clinical presentation, or would it be a double trouble condition considering the genetic limitation, the congenital hypothyroidism, irregularly controlled, and the dengue infection previously? And to say dengue infection, in this article from Brazil, we have some patients that had dengue, had rhabdomyolysis, and went for muscle biopsies. And they had lipid accumulation, just like our patient did on muscle biopsy. I would like to say thanks to all of you, and thanks to our neuromuscular disorders team here in the University of São Paulo and the ICGMT. Many thanks, and I'm waiting for the question and answer.
Thank you, Rodrigo. It was very interesting. My comment first is that, yes, we have seen necrotizing autoimmune myositis after viral infections. So I'm not surprised to see it after the arbovirus. So that it's not uncommon at all. The second is the histology is a little puzzling because you don't see lipid accumulation in necrotizing autoimmune myositis, so it's the question of sort of a dystrophic process cannot be excluded here. But we can, I don't want to capitalize on this. I want to hear from other people. Maybe Andrew can have any comments. Andrew Mammon has already put a question. Any ideas about why virus might trigger this disease? Domingo, can you respond to that?
Yes, to be fair, I really don't know, but we tried to conduct a comparison of the thinking about molecular mimicry as we have in Campylobacter jejuni and Guillain-Barré syndrome. We try to compare the structure of some of the main epitopes of dengue virus and some of what we would expect to be the aim on the HMCR antibodies, but we couldn't find any correlation with that. So I believe that this would be more a general process, perhaps, as we've seen this kind of trigger in other infections, but I really don't have a more accurate thought about how is the process going on.
Yeah, we do not have time for another question. So based on the list here, so thank you very much. I appreciate your talk, and we'll move to the next speaker, which is Dr. Tassin Hasmar. So we'll Mozafer. So we'll see Tassin on the screen.
My name is Tassin Mozafer. I'm a professor of neurology and pathology at University of California, Irvine, and I will be giving this talk on future therapies and IBM based on the immunophenotypic T-cell observations that have been made in this disease. These are my disclosures, and being in the rare and ultra-rare disease space, we have a lot of interaction with industry, and I advise them on clinical trials in myositis. Inclusion body myositis is not a new disease. It's been around since 1978, although the first description may have happened in 1968. The complete details of the disease as an entity are attributed to Sterling Carpenter and to George Carpati, both from the Montreal Neurological Institute. And in their seminal paper in 1978, they described 6 of their own patients and then reviewed another 8 from the literature, and pretty much described all the hallmarks of the disease, including slowly progressive painless weakness, no myalgias, distal weakness, the male predominance, this lack of skin lesions or connective tissue disease, the pathological findings of denervation, as well as characteristic vacuoles and mitochondrial changes. This is what we typically describe the disease to our trainees. You have very prominent quadriceps and thigh atrophy and weakness. There is a particular pattern of long flexor weakness in the forearms, in the upper extremity with marked asymmetry, and inability to make a complete fist. There may be subtle or early muscle atrophy, which can not only be seen clinically, but MRI has become a very helpful tool to define the stir abnormality, which usually represents muscle edema or muscle inflammation, but also gradual fat replacement of the muscle fibers. And when you see this characteristic pattern, especially the sparing of the rectus femoris, it's a relatively easy diagnosis to make. The muscle pathology described by Sterling Carpenter and George Carpati were very classical. So there's a marked muscle fiber variability. There are basophilic fibers, which are regenerating fibers, as well as necrotic fiber. There is muscle fiber invasion of non-necrotic fibers. There is rimmed vacuoles, these tubulofilamentous inclusions, as well as mitochondrial changes suggestive of cytochrome oxidase deficiency, in particular proteinopathy with P62 or TDP43. And these are additional immunohistochemical changes. There is a marked strong upregulation of MHC class 1. As I mentioned, there is P62 upregulation, TDP43 mislocalization, and a variety of immune cells that are present. Based on these inflammatory changes, there were attempts made in the past with immunosuppressive therapy, but unfortunately, almost all of these therapies have failed, including steroids, methotrexate, antithymocyte globulin, IVIG, oxandrolone, interferon therapies, eltuzumab, and bimagrumab, which is a muscle builder, as well as arimoclomol, which is a protein stabilizer. So it's been a really sad, long history of failure of medication, and that led to the idea that maybe the inflammation is not the primary pathology in IBM. But that is changed over the last few years. There have been an increasing number of papers that have highlighted the inflammatory disorder. So starting with Steve Greenberg's description of plasma cells that he discovered in muscle fibers, in muscle of patients with IBM, and then he showed further that there is a immunoglobulin transcript that is produced by these plasma cells, which seem to be clonally restricted and clonally driven. This led to the seminal findings of specific autoantibodies that are produced in IBM that were not seen in polymyositis and minimally seen in other diseases. These were labeled as NT5C1A antibodies, described in this paper by Larman in Annals of Neurology, and in a subsequent, in another paper that was from the Dutch group that also described the same antibodies in IBM. Steve Greenberg group beautifully showed that these antibodies localize to the rimmed vacuoles and seem to have very high specificity in IBM, but depending on where you draw your cutoff, variable amount of sensitivity in terms of diagnosis. My group, with Namita Goyal as the first author, showed that anti-5C1A antibodies in IBM rendered a more severe phenotype to the patients, mainly in terms of motor phenotype. These patients tend to have more dysphagia and a reduced life expectancy. This forest plot actually shows that presence of seropositive to anti-5C1A predicted a lower force vital capacity, a lower inspiratory force pressure, a higher score on the modified oculobulbar facial respiratory score, as well as predicted a higher facial weakness. This has been corroborated by many studies, including the large study of 300 patients that James Lilleker led, and confirmed some of the findings that we reported. Interestingly, it also confirmed the life expectancy issue. Patients with seropositivity on an average lived 8 years less than patients with no antibodies. And this paper in Annals of Neurology from Tawara did an elegant set of experiments where they took patients' serum from IBM patients and showed that it led to specific changes in the muscle, suggestive of defects in autophagy and clearance of protein aggregates, only from serum that were taken from seropositive IBM patient and was not seen in seronegative, suggesting for the first time that the inflammatory dysfunction is what drives the degenerative agenda rather than the other way around, where the thought had been that degeneration leads to presence of these antibodies, inflammatory changes. Steve Greenberg finally further built on this and showed that the lymphocytes present in IBM appear to be highly differentiated and terminally differentiated, and are more than likely to express KLRG1 ligand, which is one of the ligands for terminally differentiated cells. The lymphocytes in the blood and muscle of these patients tend to lose their CD28 ligand. They start expressing CD57 ligand and will express KLRG1. And he showed that a number of these terminally differentiated T cells in patients in serum as well as muscle express KLRG1, and there was overall a CD8 prominence in the muscle as well as blood. I'm working with Steve Greenberg as well as with Armando Vialta, who's our physiologist. Namita Goyal and I showed that majority of the T cells in IBM are highly differentiated terminal effector memory cells. So if you look at the graphs, you can see that most of these cells express high levels of CD8 positive effector memory cells, and there is a high percentage of cells that express KLRG1, which is above and beyond what would be expected with just the aging process. They seem to be on a CD8 background, and in addition, there appears to be a downregulation or deficiency of Treg cells, which are your regulatory cells. So the common immunological abnormalities are suppression of Tregs, but also increase in the level of CD8 positive terminally differentiated memory cells, which would be considered as TEMRA. These represent chronically overstimulated and exhausted T cells, and this is a special class of cells that may be less responsive to immunosuppressive therapies. There's also widespread immune and interferon gamma related disturbance in IBM. This is work from the Chinese group that showed that if you look at muscle transcriptomic signature, there seems to be a very high gamma interferon signature. And if you look at various myositis, there is IBM has the highest interferon gamma signature compared to antisynthetase syndrome, dermatomyositis, or necrotizing autoimmune myopathy. So a number of groups have been looking at these abnormalities, and now the paradigm appears to have shifted, where the paradigm has shifted to the idea that it's the inflammation that seems to be the primary abnormality in IBM, and the inflammation is what appears to be driving the degenerative changes in IBM. So the initial changes being a autoimmune assault, and the muscle, there is a Treg deficiency that leads to dysregulation of the immune system. You get presence of cytotoxic CD8 cells and plasma cells with antibodies, and there is a general cytokine response, but ultimately it drives the degeneration with creation of ER stress, protein aggregation, vacuolization, disruptance or dysregulation, autophagy, and the proteasomal pathway, ultimately resulting in muscle dysfunction, myofiber defects in myofiber regeneration, as well as a myopathic deficiency on that. More recently, people have looked at the IBM muscle, and this is work done by the Finnish group led by Professor Bjorn Ud, and they have shown that there is, if you look at the transcriptomic and signals and other signals in the muscle, the highest expression of genes and proteins are genes that are related to T cell receptor signaling, T cell exhaustion signaling pathway, the calcium signaling pathway, and these pathways that increase resistance to apoptosis, which is a normal cell death mechanism. And it's the lack of T cell regulation as well as the loss of apoptotic control of cytotoxic T cells that may underlie the lack of immune response to immunosuppressive therapy. So it's in the famous question about chicken or egg, it's, I think, becoming really clear that is the inflammation that comes first, and the aging milieu of the cells, given that these patients are usually above the age of 45, is what's promoting some of the inflammatory responses, especially the gamma interferon signaling, the MSC class 1 upregulation, the induction of the NF-kappa B pathways, as well as some of the cytokine pathways. But ultimately, that inflammation may be causing the muscle degeneration, including mitochondrial defects, the muscle proteolysis, the protein aggregation, as well as lack of protein synthesis. However, this may be relevant to other diseases as well, and I proposed a few months back the concept of inclusion body myositis as a spectrum disorder. It's a continuum. So if you start with polymyositis, which is increasingly rare, the immune responsive T cells in polymyositis undergo a phenotypic change, and they become more apoptotic resistant, they become less treatment responsive, and there is a progressive accumulation of mitochondrial changes in the muscle, then leads to protein aggregation and some of the degenerative changes that classically define early inclusion body myositis as well as late inclusion body myositis. And it's, again, you can follow the progression of the inflammatory changes, the change in phenotype of the lymphocytes. The lymphocytes become increasingly more immunosenescent and become increasingly more terminally differentiated, and that influences the muscle phenotype as well as the clinical phenotype. So just a quick word about senescence. Senescence is a pathway that occurs with aging, and it includes a number of factors that happen. So the chronic inflammation and the overstimulation and exhaustion of the muscles also results from telomeric dysfunction and the oxidative stress. It leads to these immunosenescent cells that create a pro-inflammatory milieu, and there are secretable factors then that activate these bystander cells, as well as recruit other immune cells, and ultimately produced a lymphokine or cytokine signature that results in the following abnormality. So we know that in the senescence pathway, there is a RAS-induced senescence. RAS is an oncogene. There are abnormalities related to signaling of the growth factor pathway, as well as the PI3 kinase signaling pathway. And then the reactive oxidative stress also influences that. One of the main targets seems to be the mTOR pathway, which is the mammalian target of rapamycin, which is essential in muscle growth, as well as the lack of this pathway or the inhibition of this pathway leads to muscle atrophy. These are drug targetable, so they are newer agents, morphics, as well as inhibitors of some of these secretable proteins that are associated with senescence. So there is an entire group of medications that potentially can be used for these senescent cells, and the term used for them are senotherapeutics. Senotherapeutics could be senolytics as well as senomorphic, including steroids. But again, the targets that we would approach will be different depending on which pathway in the senolytic or the senescent pathway do we want to target. And this is a list of potential medications that can be used for this purpose. So based on all of this, I think there are opportunities to introduce newer and novel therapeutics in IBM. Some of these are already going on. So for instance, targeting these highly differentiated T cells, one strategy would be to use specific immunodepletion. And this strategy is already being undertaken by a company which has introduced a specific immunodepletatory therapy titled AB008. This has completed phase 1 trials and is starting to recruit for phase 2 trials. This is by a company called Abcuro. There are senotherapeutic or senolytic approaches, such as combination of dasatinib and quercetin, which has been used in other medical conditions for treatment of these senescent cells, and that's something that's being planned in IBM. There is a trial that is ongoing internationally, including 2 sites in the United States, which is using sirolimus or rapamycin, which we know is an mTOR inhibitor. And again, this would be acting at mTOR as the primary pathway that's affected by senescent cells. The other strategy would be to upregulate T regulatory cells. This has been shown in ALS, for instance, or Lou Gehrig's disease, with ex vivo expansion of polyclonal Tregs cells and then infusing it back to the patient. These are autologous Treg cells. This was taken by Stan et al. For treatment of amyotrophic lateral sclerosis. But then there are companies that are using a IL-2 mutant based upregulation of Treg cells. This is becoming quite the hot commodity in immunology, and there are multiple companies, including AbbVie and Merck, that have specific drugs based on IL-2 mutant, and the strategy there would be to upregulate Treg cells. You can also create specific chimeric antigen receptor Tregs with muscle specificity and suppression of bystander suppression effect. And then because we know there is a prominent plasma cell and B cell response with specific production of antibodies, you can potentially target B cells and plasma cells. So proteasomal inhibitors such as bortezomib would be one strategy. Or you can create specific chimeric receptor T cells, which are directed to CD19 or to B cell maturation antigen for use in patients who are antibody positive to suppress the antibody levels and reduce the severity of the disease. So I'm going to end here. I'm happy to take any questions in the question and answer sessions. Thank you for the opportunity to speak at the Brain Conference 2023. Thank you.
Yeah, thank you, Tassin. Unfortunately, we don't have time. There are too many questions. but no time for questions, so we'll keep that for another time. As you know, I'm a strong advocate of T-cell of immune response in IBM, and we have shown extensively with the in vitro studies and in vivo studies that the inflammatory cells drive degenerative molecules. So I'm not surprised by that. So, well, we have to continue with the next speaker because there's no time for us.
Hello, everybody. I'm Iago Pinal Fernandez, staff clinician from the Muscle Diseases Unit at NIH. I'm going to present today the project Transcriptional De-repression in the muscle of patients with dermatomyositis and anti-MI2 antibodies. As you all know, myositis is a collection of autoimmune diseases, and among them, one of the syndromic groups is dermatomyositis. And it is key in patients with dermatomyositis to understand the different autoantibodies because they are associated with very specific phenotypes. So the four more frequent autoantibodies in dermatomyositis are anti-MI2, anti-NXP2, anti-T1 gamma, and anti-MDA5. And the clinical features are very different. For example, anti-MDA5 patients have very severe interstitial lung disease, whereas anti-T1 gamma and NXP2 and MA2 usually don't have any lung involvement. Anti-T1 gamma is highly associated with cancer. Anti-MI2 and NXP2 are more myopathic than anti-T1 gamma and anti-MDA5. Of all of these antibodies, I'm going to focus today on one, anti-MI2, the most myopathic of all the dermatomyositis. Anti-MI2 antibodies recognize antigens of the NURTH complex, specifically CHD3, CHD4, and probably CHD5, which have a high structural homology. The NURTH complex is a transcriptional de-repressor, and this will be important at the end of the talk. When we did our first studies in anti-MI2, it was obvious that these patients were overall weaker, and they had more severe weakness, and they had higher CK levels than other patients with dermatomyositis. Here on the y-axis, you have the strength in blue, the CK in yellow, and in the x-axis, you have the years from the first visit. And you can see that at the beginning, these patients are weak, have high CK levels, but they recover the strength very well with the conventional immunosuppressant treatment. The other thing that was interesting when we looked at the biopsies of these patients was that some of them had muscle necrosis as the main pathological feature. It was not the typical dermatomyositis. Many of them were classified as necrotizing myositis, even when they were clinically very clearly dermatomyositis. A few years ago, we started doing transcriptomic analysis. And to do an RNA-seq of the muscle, we homogenize the muscle, we extract the RNA and prepare the library. We sequence it to get a snapshot of what RNAs the muscle is making at a certain time point. And in our first studies, it was very obvious that some genes were only expressed in patients with certain antibodies. Particularly, for example, MAdCAM was only expressed in patients with anti-MI2. At this moment, we detected that it was not an isolated phenomenon. It was not only a couple of genes, but it was a whole set of genes that were overexpressed in patients with anti-MI2. And today I'm showing you the in-depth analysis of this transcriptional program that is deregulated in patients with anti-MI2 antibodies. So here in the x-axis, you can see NT is normal tissue, normal muscle biopsies. The second column is the anti-MI2, then dermatomyositis patients without anti-MI2 antibodies, antisynthetase syndrome, IMNM, and inclusion body myositis. In the y-axis, you have the expression levels in a log scale, and you can see that all of these genes, the most differentially overexpressed genes in anti-MI2 dermatomyositis, many of them are not expressed at detectable levels in non-anti-MI2 muscle biopsies or normal skeletal muscle. They were all overexpressed. It was no underexpression, at least in this first set of genes. And they were unrelated to the interferon pathway. Even the IFI-TM5, even if it has interferon in its name, is not an interferon-inducible gene. So to define formally this set of genes, what we did was do all the pertinent comparisons between anti-MI2 and dermatomyositis, anti-MI2 and antisynthetase, MI2 and IBM, anti-MI2 and IMNM, anti-MI2 and normal tissue, and select those genes that were overexpressed simultaneously in all of these comparisons. We obtained a set of 135 genes, as you can see in this graph, showing this heat map we are seeing the C score. Red means higher expression, white lower expression. On the left column, you have patients with anti-MI2. Each one of the columns is a single patient, and each one of the rows is each one of the 135 genes that we identified. You can see that all of these genes are only expressing anti-MI2, are not expressing patients with dermatomyositis without anti-MI2. The second thing that we saw was that these 135 genes were correlated among them. So in the rows and in the columns, you have the set of 135 genes. What you see in this heat map is the Spearman correlation. Red means high positive correlation. Blue means high negative correlation. And you can see that all of these genes are highly correlated between them. And the third thing that we saw was that it was a correlation between the expression of these genes and the presence of inflammatory markers, markers of muscle regeneration, and an inverse correlation with markers of adult muscle. So here you have the most expressed genes in anti-MI2. This is a heat map of the Spearman correlation. Red means positive correlation, blue means negative correlation. And in the first column, you have the titer of antibodies. So these genes are correlated with the titer of the other antibodies. Then you see markers of type 1 interferon, ISG15 and MX1. They are correlated with markers of type 1, markers of type 2 interferon, GBP2, IFI30, then markers of T cells, CD3, CD4, CD8, markers of macrophages, CD14, CD68, markers of muscle regeneration. And then you see the negative correlation with markers of structural proteins of the muscle, actin and myosin. Sure enough, this was not only observable at the transcriptomic level, we could also see that it was a correlation between the expression of these genes and the appearance of the muscle biopsies. Here you have 9 different muscle biopsies of patients with different levels of these genes that I was talking about. SCRT1 is the most specific gene anti-MI2. And you can see here on the right corner of each one of these images, the expression level of SCRT1. And you can see that the higher the level of SCRT1, the more necrosis and the more inflammation. As the levels get lower, the muscle biopsy is more and more normal. So as a conclusion, muscle biopsies from patients with anti-MI2 positive dermatomyositis are characterized by the overexpression of a set of more than 100 genes, some of them not usually expressed in the skeletal muscle. The expression level of these genes are correlated with the titers of anti-MI2 antibodies and with markers of disease activity. The expression levels of the members of this gene set are mutually correlated. And we believe that this is interesting because first, this study confirms that anti-MI2 antibodies define a distinct subtype of dermatomyositis. And second, going back to one of my first slides, you remember that these antibodies recognize members of the NURT complex, and the NURT complex is a transcriptional D repressor. Our data suggests the possibility that the MI2 antibodies may exert a pathogenic effect by inhibiting the NURT complex and D repressing genes, the genes that we define in this study. Thank you very much.
We don't have another question, but I can ask since we have 1 minute or so. Is the phenotype of these patients different from the other patients with dermato?
So what was very clear that the anti-MI2 and anti-NXP2 are more myopathic than T1 gamma MDA5. For example, comparing them to MDA5, they have a really clearly different phenotype. Comparing MI2 with NXP2, NXP2 patients have more finger extensor weakness, but they are more difficult to differentiate. Transcriptomically, they are extremely different. Transcriptomically, we can pick up the patients with MI2 very easily.
Okay. Okay, well, we don't have another question from the audience, so we should proceed to the next and final speaker, which is Professor Marilyn Needham. So we'll be waiting for the slides to appear and Marilyn to come on. So since we have time until, can you hear me?
So Iago, since we have time, can I ask a question?
Sure.
In relation to MI2 and the risk of malignancy, I mean, the conventional thinking was that MI2 patients don't get as much malignancy, but I think lately that's been challenged. What's been your experience and how aggressive do we need to be in terms of screening for malignancy?
So that's a great question. When we did our cohort analysis reviewing all the MI2 patients, the Hopkins cohort, we couldn't find an association with cancer, and the cohort was pretty large. I know that in Europe there have been some cohorts that have found, I would say, compared to TIP1 gamma, pretty limited risk of cancer. Practically, we still do the cancer screening in MI2 patients as if they were other dermatomyositis patients, but I think it's clear that most of the cancer risk is in TIP1 gamma, and NXP2 has a lower risk, but detectable, we could detect it in our cohort. MI2, I think, is lower than NXP2.
So since we have also time waiting, Tassin, can I ask you a question about can you hear me? About the KLRG1 cells, do you think they're pathogenic to do a trial to target them?
Yeah, so I think in our studies, the only significant correlation we saw was disease duration in terms of KLRG1. We unfortunately were not able to show any specific correlation with disease phenotype with KLRG1, which concerns me a little bit in terms of whether depletion will work or not. I think part of the challenge is that, and at least it's my bias, but I think there's some suggestion that the inflammatory process-induced degeneration may become autonomous at some point, which means that there is a point of no return. So if you catch the disease early, there may be a higher chance of making an impact versus doing it later in the disease. And my understanding is that at least, my understanding is that at least in the Epcuro study, there is not a disease duration requirement, which may become a little challenging.
Yeah, we did very strong with alemtuzumab, so which is you eliminate a lot of cells. So, but to target this subset, you need to make sure these cells are really toxic, cytotoxic to the muscle fiber, or trigger neurodegenerative molecules. So, but anyway, as you said, it's a challenging issue here, but we'll see. Not sure if we're ready for Marilyn. Ready? Okay.
I would like to thank the conference organisers for inviting me to speak to you today on the current evolution of clinical inflammatory myopathies, from immunopathology and neuromuscular neurologists to myositis autoantibodies and clinical rheumato-neurologists. Really, what I'm hoping to cover today is the history and evolution of myositis classification and diagnostic criteria. It's important to note that myositis has been recognised for well more than 100 years. And in fact, in 1863, the subgroup associated with the skin rash, now known as dermatomyositis, was separated from the other forms of myositis. It wasn't really until 1975 when some landmark clinico-pathological diagnostic criteria published by Bowen and Peter were used for more than 30 years, really, from that time. This was a seminal paper. However, by the early 1990s, inclusion body myositis came to be separated formally from polymyositis. By the early 2000s, investigators started using antibodies in defining their different classification criteria for different forms of myositis, moving into an era of clinico-seropathological criteria. From 2010 really to current, there's been an increased understanding on the limitations and strengths of these myositis-specific antibodies, radiological features, and more detailed understanding of immunopathogenesis and histopathological studies, leading to clinico-sero-radiological pathological criteria. Why does this matter? Well, I think as doctors we can be either splitters or lumpers. When we don't really understand disease immunopathogenesis, we tend to lump them all together into big groups that helps us clinically put patients into one category or another. But the more we understand the immunopathogenesis of these disorders, we're starting to really split them. And this is because they have important prognostic and treatment implications for patients, because the immunopathogenesis for some of these disorders is quite different, and their response to treatment is also quite different. This diagram that was first published by Tamboon and colleagues is a really great one that takes us through the development of different diagnostic criteria based on whether they were clinically orientated, like these very early ones, clinico-pathologically orientated, like these orange ones dotted through here, and then the addition of the antibodies with these green diagnostic criteria through here, and then finally to clinico-seropathologically orientated, one of the more recent ones from the ENMC in 2018. In addition, along this timeline, you can see the development of the myositis-specific antibodies. And I think this is a diagram we're going to keep coming back to today. So to begin, at the beginning of the first seminal diagnostic criteria, back to 1975 to the Bowen and Peter criteria. And the reason for looking at this is important because many clinical trials and clinical series still continue to quote these criteria. And so I think it's important to understand why they were developed and their limitations. Really, the Bowen and Peter criteria were developed to distinguish idiopathic inflammatory muscle disorders from other muscle disorders like inherited muscular dystrophies. They used the clinical criteria of the pattern of muscle weakness being a symmetrical limb girdle pattern of muscle weakness progressing over weeks to months, plus minus the involvement of dysphagia or respiratory muscle weakness, in addition to dermatological features such as the heliotrope rash, Gottschon's papules, and a V or Shaw rash, alongside the investigation results of a elevated CK and often aldolase, LDH and transaminases, EMG triad of small, short polyphasic motor units, often with fibrillations and positive sharp waves and increased insertional activity, along with bizarre high-frequency repetitive discharges, along with the muscle biopsy evidence of necrosis, phagocytosis and regeneration of muscle fibres, variation of muscle fibre size, and an inflammatory infiltrate which they noted was often perivascular. They split the disorders into 5 clinical subgroups: polymyositis, dermatomyositis, DM or PM associated with cancer, childhood DM or PM associated with vasculitis, and finally, myositis associated with collagen vascular disease, which we now refer to as overlap myositis. Within these clinical subgroups, the diagnostic criteria were further refined as definite if you had 3 or 4 criteria, probable if you had 2 or 3 criteria, and possible if you had only 1 or 2 of these criteria. However, detailed subsequent immunopathological studies led to better characterization of dermatomyositis and polymyositis histopathologically, and provided evidence for a distinct pathogenic basis of these disorders. That is, that dermatomyositis is mainly a CD4 T cell, macrophage and B cell mediated disorder confined to the perimyceme, often associated with perivascular and perifascicular muscle fiber atrophy, with the deposition of membrane attack complex or MAC on the small blood vessels. Compared to polymyositis, which is considered a CD8 T cell mediated disorder and usually associated with MHC1 upregulation on the cell surface of muscle fibers. So these criteria had significant limitations in distinguishing one form of myositis from another. But remember, that wasn't the purpose of these criteria in the first place. In addition, there was a lack of recognition of different subtypes, like, for example, amyopathic dermatomyositis, or the antisynthetase syndrome presenting with extramuscular manifestations like interstitial lung disease. Immune-mediated necrotizing myopathy wasn't recognised as a distinct subclass of polymyositis at this time, although the original publication did note that some patients had extensive necrosis and regeneration with a lack of inflammatory infiltrate, even back in 1975. And there was a lack of recognition also of inclusion body myositis. Moreover, these criteria predated the boom in myositis-specific antibody discovery, so they do not reflect our current appreciation of the clinico-seropathological subcategories of inflammatory myopathies that we recognise now. In the early 1990s, inclusion body myositis, or IBM, was formally separated from polymyositis. But in fact, it was back in 1967 when Chow first described distinct intranuclear and cytoplasmic filamentous inclusions and vacuoles, and these were initially thought to be chronic polymyositis associated with chronic viral infections. But throughout the 1980s, the term inclusion in body myositis, or IBM, was increasingly being used for describing cases of a distinct pattern of muscle weakness involving predominantly quadriceps and forearm flexors that were resistant to steroid therapy. And it was in the early 1990s that the pathological features with amyloid deposition and increased mitochondrial changes, as you can see here with the increased COX-negative fibers, began to be recognised as a distinct subtype. So in the 1990s, there was a real change in the clinical and pathological criteria of inflammatory myopathies. There was clearer clinico-pathological criteria. For example, Delakis in 1991 published some clinico-pathological criteria for dermatomyositis, polymyositis, and inclusion body myositis. And the ENMC in 2004 published some clinico-pathological criteria for dermatomyositis, polymyositis, immune-mediated necrotizing myositis, and non-specific myositis, which were critical for the development of clinical trials throughout the next decade. However, it was through the 1990s that clinicians started seeking more specific criteria that started including further developments in the field, and most specifically through this decade was in the inclusion of some myositis-specific antibodies. For example, in 1991, Love and colleagues suggested a new set of diagnostic criteria for myositis that for the first time incorporated myositis-specific antibodies, including anti-Jo1, anti-My2 antibodies, and anti-SRP antibodies. Troyanov in 2005 followed this, also emphasising the clinico-serological correlations, particularly separating out the overlap myositis with myositis-associated antibodies from polymyositis. And I'm just going to briefly show you some histopathological pictures so you can really appreciate what we're referring to here. So for example, in this top panel, you can see an anti-My2 dermatomyositis section showing perifascicular muscle fiber necrosis and regeneration with expansion and fragmentation of the perimyceal connective tissue, which is best seen here on the alkaline phosphatase stain in the anti-My2 dermatomyositis muscle. The next panel shows NXP2 associated dermatomyositis, which shows a whole section of myonecrosis and regenerating fibers just adjacent to this yellow, sharply circumscribed area of muscle infarction. The fourth panel here, 9D, shows a very strong perifascicular MHC1 staining in the case of an anti-My2 antibody-associated dermatomyositis, whereas panel E and F show anti-TIF1 gamma dermatomyositis, again showing a more subtle perifascicular, subsarcolemmal and sarcoplasmic MHC1 staining of muscle fibres, and MAC deposition here in the perifascicular region. And these photographs are thanks to Dr. Jason Dyke, who's our neuropathologist here in Perth. This has also been published by Tamboon and colleagues, where you can see different histopathological features associated with the different dermatomyositis-associated antibodies. And just to contrast this, for example, with antisynthetase syndrome, which shows widespread myonecrosis regenerating fibres, along with endomycel lymphocytes and histiocytes, and striking perimycel connective tissue fragmentation, where you can see this most clearly again on the ALP stain. This third panel shows very strong and diffuse sarcoplasmic and sarcolemmal staining by MHC1 on all non-necrotic fibres, as well as quite strong intensity of the MAC terminal complement staining of necrotic fibres and circumferential sarcolemmal staining of the non-necrotic fibres. So again, showing this in contrast to immune-mediated necrotizing myopathy slides that show regenerating fibres along with some necrotic fibres, but with minimal inflammation really confined to macrophages phagocytosing the necrotic muscle fibres. Here in panel B, you can see some longitudinal regenerating fibres seen here with the blue fibres. And in panel C, you see widespread sarcolemmal staining of non-necrotic fibres by, again, the MAC stain, and widespread subsarcolemmal and sarcolemmal MHC1 staining in the case of immune-mediated necrotizing myopathy. And the necrotic fibre shown here with the asterisks is strongly MHC1 positive. And this is again in contrast with inclusion body myositis, where here in panel A you can see a high magnification of a single fibre with lymphocytes invading non-necrotic muscle fibres. Again here you can see perimycel blood vessel with circumferential lymphocytic cuffing, but no evidence of vasculitis or damage to the blood vessel wall or endothelial lining. In panel C you can see the Gamori stain showing a ragged red fibre with an adjacent fibre showing numerous rim vacuoles here. Panel D, you can see multiple COX-negative fibres. Panel E, you can see very strong and diffuse MHC1 staining in inclusion body myositis. And panel F, you can see the P62 positive subsarcolemmal aggregates shown with these arrows. So certainly there is a role, I think, for ongoing and detailed histopathological studies. And I think there's an imperative for clinicians to be really all over what the muscle biopsy features should look like and what to expect with different antibody and clinical subtypes. But over the last decade, clinicians have continued to search for more specific and less invasive disease markers. And in particular, the search has deviated into myositis-specific antibodies, MRI and imaging findings, as well as transcriptomics, including interferon signatures. And this has led to more specific histopathological stains, for example, the myxovirus resistance protein or MXA stain, which is quite specific for dermatomyositis. So again, coming back to this timeline, you can see the development and identification of these various myositis-specific antibodies from 1976 with anti-My2b, with the most recent antibody we've discovered, the CN1A for inclusion body myositis, although there have been a few others. So one way to represent this is to break down the disease subtypes by antibody. The myositis-specific antibodies are now increasingly being recognised for their value in prognostication, involvement of extramuscular organs including lungs, joints and skin, as well as identifying patients at high malignancy risk. You can see by this table the prevalence of autoantibodies or myositis-specific antibodies in the immune-mediated myopathies. They have quite a low prevalence, in fact, across the board, and this is perhaps relevance when we're looking at the sensitivity and specificity of these antibodies. There are multiple different assays used for these myositis-specific antibodies. The gold standard is still considered immunoprecipitation, but this one is limited in the number of patients and throughput and the risk to lab technicians. So increasingly, line immunoassay, which is rapid technique with a good quick turnaround and can do multiple patients simultaneously is widely used but has limitations. People are looking at Albia technology as well as particle-based multi-analytic technology. And just to show you a picture of the immunoprecipitation versus immunoassay. There's been quite a lot of very good papers that I can commend to you that talk about the role and the controversies of these myositis-specific antibodies. I think it's fair to say that in a broad assessment of the autoantibodies, a line blot assay that covers all currently available autoantibodies in myositis would be preferable, but this currently is not available. When we look at the myositis immunoblot and how it performed in our population reference data, what you can see here is that although the vast majority of patients did test negative on the line immunoassay, still a significant proportion of what we would consider healthy controls tested positive for a number of these antibodies. And this has also been noted across the world. So there are significant concerns over the line immunoassay that's currently being used globally. There's a lack of true quality controls and calibrators. Reproducibility is limited. Across the population, there's a low prevalence and incidence of idiopathic inflammatory myopathies and a low prevalence of the individual markers within those IAM cohorts, which leads to a lack of sensitivity for some of the analytes and some subjectivity in interpretation. So I think understanding the importance of positive and negative results requires close collaboration between clinicians, histopathologists, and immunologists. And just by way of example, you can see from this study that was published in Frontiers of Immunology in 2019 that out of 76 dermatomyositis patients and 31 polymyositis patients, 15 unknown, 11 overlaps and 8 juvenile and a few others, with a high prevalence of myositis-specific antibodies, the best correlation between these different techniques in testing for antibodies was for SAE antibody. But there were marked, pronounced differences between the particle technology and line immunoassay, particularly for the anti-My2 antibody, anti-PL7, anti-EJ, and particularly TIF1 gamma, which is super important when trying to understand the malignancy risk for patients. So again, another way to represent the different antibodies associated with the different clinical phenotypes. And just to race through, I'm sure this audience doesn't need to be told or see dermatomyositis with the various skin rashes, the immune-mediated necrotizing myopathy, which is really marked by a spectrum of pathological alterations where there's necrosis but often florid regeneration, but with no or few inflammatory infiltrates. And traditionally, although defined as no complement deposition, recently there's been recognised as some sarcolemmal complement deposition can be on scattered fibres, but in a different distribution to dermatomyositis. And so there are some required pathological features still required for necrotizing myopathy. But the etiology of this disorder is associated with various antibodies, and in particular the HMGCR antibody, as well as the anti-SRP antibody. So where those antibodies are present and they're well tested and they fit clinically, perhaps there's no need in these subgroups to necessarily do detailed immunopathology, but certainly for seronegative cases there would be. There are anti-synthetase syndromes, which you're all familiar with, which are associated with the anti-tRNA synthetase antibodies. Anti-Jo1 is the most commonly seen antibody here, and these often have a poor response to immunotherapy. As compared to some of the other forms of overlap myositis, for example, this one associated with anti-RNP antibody, which has pretty good response to treatment. Even more recently, we're adding other non-invasive tests, particularly radiological ones. For example, ultrasound can be a very useful bedside test to see the difference between this normal vastus lateralis on the left compared with this increased echogenicity seen in vastus lateralis on the right. And when trying to detect, for example, inclusion body myositis, you can see the increased signal here in flexor digitorum profundus compared to flexor carpi ulnaris. MRI is being increasingly used in neuromuscular disease, and you can see here the patterns of muscle involvement seen in immune-mediated necrotizing myopathy. When screening for malignancy, PET scanning is being increasingly used, And you can not only use this to identify malignancies, but also increase muscle signal, which can demonstrate some disease activity. So I think it's important to note that one of the more recent diagnostic criteria, which has been recently published, doesn't incorporate many of these. So the question I had for you was, are we there yet, given the evolution over the last 3 decades or so? And the answer to that is probably not yet. This EULAR ACR classification of immune-mediated myopathy was really developed by an international group of IAM experts, including adult and pediatric rheumatologists, neurologists, dermatologists, epidemiologists, and biostatisticians. And these applied 93 variables from both previous and current cases and applied to 976 inflammatory myopathy cases and 624 non-IAM cases from 47 centres across the world. 2 models with and without muscle biopsy results were developed to better reflect some of the clinical settings, particularly pediatrics, where performing muscle biopsy standards is not a standard of care. Unfortunately, there are lots of limitations to this current accepted criteria. There were no controls or comparators included in the external validation cohort, and the observational data used to develop this frequently missed data points. And although more than 80% of patients had muscle biopsy data, only 38% had MRI data and 29% had EMG data, for example. Patients had to have their disease for more than 6 months, making it difficult to apply to new patients. And these criteria were actually developed for the purpose of research and inclusion into clinical trials and not for diagnostic criteria. It took almost 10 years to assemble a sufficient patient numbers, and some subgroups still did not have sufficient number of subjects. For example, the immune-mediated necrotizing myopathy group. Only one myositis-specific antibody, and that was anti-Jo1, was sufficiently documented to be used. And so when the necrotizing myopathy and antisynthetase syndrome really fell under the heading of polymyositis, which is really outdated because these disorders have distinct clinical course and response to therapies. So I think we're in a stage where there's a need for new diagnostic criteria that need to evolve to reflect epidemiologic and molecular advances in idiopathic myositis. So in conclusion, I hope you can see the evolution of the myositis criteria through the last 3 decades. Initially, it was a correlation between clinical features, but with an emphasis on histopathology. More recently, we've started to include myositis-specific antibodies, as well as myositis-associated bodies, as well as inclusion of more disease-specific pathways, which has led to more specific immunohistochemical stains, including the interferon transcriptomics and the myxoma virus stain. More recently, radiological findings are being valued as being able to distinguish one form of idiopathic myositis from another. And I think the art of medicine for the clinician is combining these all together to the individual patient to come up with a cohesive picture and an answer for our patients. Thank you very much for your attention.
Thank you, Marilyn. It was very nice, but we have unfortunately no time for questions because we're 5 minutes late. Clearly, you raised a lot of issues, whether the myositis antibodies are really specific or it will be associated antibodies, should be called myositis associated antibodies or myositis specific antibodies, and whether the antibodies will replace the muscle biopsies. That's certainly a number of issues that we at some point need to discuss extensively. So thank you very much, everybody. It was a wonderful short series of talks, and I think have been all very insightful. And I don't want to take more time because we have no time. Thank you, thank the organizers of BRAIN for putting this together.